So welcome back, everybody. We're going to move on now and talk about one of my favorite topics, biliary tract cancers. We call it the new non-small cell lung cancer. So we're really thrilled today to have Dr. Amit Mahipal from the UH Seidman Cancer Center in Cleveland and Dr. Mitesh Borad from the Mayo Clinic in Phoenix, Arizona. From the Florida Cancer Specialist, we have Fei Yin from Spring Hill, Florida. And Dr. Borad, who was nice enough to say that Joe Rogan is the Neil Love of podcasting. I thought that was kind of amusing. We know we spend more time picking the music out for this thing than anything else we do. So we should send you the playlist. Anyhow, one of the things I was talking with Fei, Dr. Borad, that she was curious to hear your thoughts about was the increasing incidence of biliary tract cancer, and where do you think that's coming from?
Yeah, there's been some speculation. It may be related to metabolic disease, obesity, NASH/MASH. And then there's a growing incidence in very young people below 50 who don't fit that mold. And actually don't have germline genetic alterations that we at least know of. So that bucket remains a mystery. And one could speculate it's because of all the additives you see in the food chain, in terms of ingredients that are, new to the human consumption. So some likely causes and some unknown ones.
Amit, any thoughts? Are you into the microbiome?
Yeah, so microbiome could be related. I think one of the big factors that has happened in the last 20 years, I would say, is that increasing recognition of the disease. When I was in training, a lot of these, we see patients with liver lesions, and we'll call it cancer of unknown primary. Like, we do all the workup, we can't find an unknown. And I think now people are realizing these are primary liver cancer. They are bile duct cancer. They are arising in the bile ducts in the liver itself. So I think with all these targeted therapies being developed and some of the obviously very specific genetic aberration like FGFR fusion, IDH1 mutation you see, and we know these are bile duct cancer. So I think that has definitely dramatically increased incidence because we are recognizing or rightly diagnosing these patients. But I agree with you, like microbiome, diet, I mean, these are definitely associated with some young onset cancer that we are seeing in all different kind of GI cancers, including bile duct cancers.
So another thing I wanted to pick your brain about before we start looking at slides, and Fei, I don't know whether you've seen any cases like this. I don't know whether people present weird cases or it's actually more common, Mitesh, which is what people call mixed HCC biliary tract cancers. I don't know, whether or not it's an entity in and of itself. It's both cancers, and also how you manage it. Fei, have you had any cases like that?
Yeah, those cases are very, confusion. I really, which one we need to focus on.
So, some people say what's more predominant histologically, but a lot of people say, well, what do you do first line, for example, Mitesh, in a patient like that, say, who has metastatic disease?
Yeah. I mean, in medical oncology, it's important to remember that those definitions are for surgeons. We don't really have to follow them as much, especially with the genomic basis of disease becoming more and more important even in therapy. So the cell of origin for intrahepatic and HCC, intrahepatic cholangiomas and HCC is felt to be the same. That's why you get some of these mixed tumors. It's emanating from the same cell. And if you look at the genetic profiles, you might see a lot of the things you might find in cholangiocarcinoma, like IDH1 mutations or FGFR2 fusion. So you could always use your profiling as a guide for later line therapy. For first line therapy in advanced patients, I think you could just use the regimen for biliary tract cancers because the checkpoint inhibitor provides coverage for HCC as well. So my own practice has been to treat these patients with GemCis plus checkpoint inhibitor.
Amit, that's kind of what I hear from a lot of investigators. Do you agree? Is that the way you approach those patients?
Absolutely, I will certainly echo that comment. So we typically would combine chemo plus IO and assuming that will take care of the both component. And also the adenocarcinoma component tend to be a little bit more aggressive in general than the HCC component, but that's hard to figure that out, as you said, like which is dominant, and that could be a biopsy sample issues as well. So.
So in a second, Amit's going to go through some issues. We're going to start out actually talking about targeted therapy of biliary tract cancer. As I say, it seems like it kind of reminds me a little bit of non-small cell, in that there are a number of potential targets there. So why don't we take a little bit of look at some of the data there and what we've been learning about this, Amit?
So I'll be talking about targeted therapy approaches in biliary tract cancer. I mean, this has really, really transformed the field in the last few years. I remember when I was training, I mean, there was just like some chemotherapy, really not effective, and it was just a disease that not a lot of people wanted to go into or make their career. And secondly was obviously we talk about that diagnosis was many times they were misdiagnosed and not correctly diagnosed as cholangiocarcinoma. So just a background, I mean, the annual incidence is about 12,000, although now it has been increasing. Some people say it's 16,000, even 20,000. And many times if you look at the SEER data, it's sometimes hard to actually tease out how many are cholangio, because they kind of like sometimes club them into called liver tumors. But incidence definitely has been increasing in the last 4 decades, as we're talking about. And we think of other GI cancers like pancreatic cancer, aggressive disease. Just to keep that in mind, in the advanced stage, the 5-year survival is less than 2% overall population. So it's really, really a highly aggressive disease, a highly lethal disease. This is just some anatomical classification. It was very, very important for the surgeons. We divided bile duct cancer into gallbladder and the 3 different types of cholangio: distal cholangio, hilar cholangio, and intrahepatic. But now it is becoming more important for us as medical oncologists, because the genetic aberrations are different based on the location or anatomical location of the tumor. So if it's intrahepatic, we tend to see more FGFR2 fusions, IDH1 mutations, as compared to gallbladder or extrahepatic, where we tend to see more like HER2 amplification, as we're just talking about targeted therapy. MSI high tumor, we tend to see more in intrahepatic cholangiocarcinoma. KRAS mutation is more common in hilar cholangiocarcinoma. So just giving a different spectrum, different targeted disease. BRAF mutation, again, which is being targeted, is again more common in intrahepatic as well. Just talking about FGFR fusion, there are multiple, more than 100 different partners. We'll talk about some of the therapy, although the therapy decision has not changed based on the fusion partner. But the common one is BIC1 is one of the more common one, but just to keep that perspective. So talking about FGFR2 or fibroblast growth factor receptor 2, there are different kind of ways it can activate it, including amplification, mutation. There's the oversecretion of FGF, and lastly is the FGFR fusion that will be our focus of our talk. And it leads to intercellular kinase pathway activation like JAK-STAT and PI3K kinase. So when the first trial, which was in this space, was with pemigatinib, which is an FGFR2 inhibitor. It does inhibit both FGFR1 and 3, but again, it's the FGFR2 fusion patients, so we are focusing on FGFR2 inhibition activity. And this is a waterfall plot, and this is something we never saw in like cholangiocarcinoma space with any of these therapies in the past. So with the overall response rate of 37% and disease control rate of 82%. And you see more and more like, a lot of these patients have some sort of response. And this led to FDA approval based on the response rate alone as a single-arm trial, which is pretty uncommon actually in this disease. So then also they look at like different cohorts in this study, focus on FGFR2 fusion, which is over 100 patients. And there the median PFS was about 7 months. We talk about the responses. But they had 2 different other cohorts, cohort B and C, which has other FGFR alteration or no FGFR alteration. And basically, you do not see much activity in those patients. So again, this drug is very active, but mainly active in FGFR2 fusion patients. FGFR2 mutation or without any FGFR2 alteration, there's very minimal activity. And similar results we translate into survival differences as well. Patient with FGFR2 fusion who received pemigatinib on this trial, the median survival was 17.5 months compared to 6.7 months or 4 months for FGFR2 altered or no FGFR alteration. Just to keep that in mind, the patients with FGFR2 fusion do have a better prognosis. So even if we were not to give treatment, they do tend to live longer. But obviously, here we are seeing more responses, improvement in PFS, and improvement in survival as a single-arm trial. Then there was another trial with futibatinib, which is an irreversible FGFR2 inhibitor. Here, again, we see activity. We see a wonderful waterfall plot. We see response rate of 43% and disease control rate of 85%. And again, looking at PFS and OS, the duration of response was almost like 9 months. PFS was 9 months, and overall survival, median overall survival was 21.7 months. So really, again, it's a single-arm trial, not comparison, but we are definitely seeing responses, right? Response we believe are true, effect of the therapy, and we have a good disease control in most of these patients. And again, just to keep in mind, these are patients who have been priorly treated, so they are refractory patients who typically have response rates with chemotherapy in the range of 5 to 10%. Some of the FGFR-related toxicity, I mean, there's been a really very, very different drug that we have used, at least in the GI cancers in the past, including toxicity, including hyperphosphatemia, hand-foot syndrome, some GI toxicities, stomatitis, dry eyes. And there are ways we can manage these toxicities, but again, just to keep that in mind that these are very, very distinct toxicities, and we should be aware of it and to manage it appropriately. So overall, again, we are seeing with the FGFR inhibitor, we have 2 drugs which are approved FDA by pemigatinib and futibatinib. Response rate in 35 to 40%, the disease control rate of 80 to 85%, at least in second-line or later therapy. There were attempts to do the first-line trial with these drugs, but unfortunately, because of slow accrual, they had to be aborted. We are awaiting data from one of those trials. Unfortunately, even with this great activity, most of these patients do develop resistance, and primarily is the FGFR2 mutation, the binding site. So we have to see what other ways we can overcome these resistant mechanisms. And there are novel therapeutic agents being developed, like RLY-4008, tinagotinib, and there are a few others that have been in development.
Before you go on, if I could just ask you a couple questions about FGFR. First, I feel like I've heard cases presented where just sort of people just mentioned that there was an FGFR fusion outside of biliary tract cancer. Are they responsive? Any thoughts about the future in terms of pan-tumor approvals?
So I think the RLY-4008 is going for pan-tumor indication, so they have seen activity outside. But it's pretty uncommon to see FGFR2 fusion. We do see FGFR1 or 3, they're a little bit different, like especially in urothelial. But yes, we have seen it outside biliary tract cancer, and these drugs seems to have some activity. Again, there are more incidental case reports, as you said.
And Mitesh, can you provide a little more granularity of what kind of tolerabilities come up with these agents? Are they different? Are they all kind of similar tolerability issues, and particularly the phosphate thing, like how you deal with that?
Yeah, the long-term tolerability is very much linked to the skin issues, particularly nails falling off as one of the toxicities, which can be quite bothersome to patients. And the second one is the ocular issues, ranging from blurry vision to retinal detachment. So having an ophthalmologist alongside with you is very critical if prescribing these drugs. The hyperphosphatemia, I would say, is more a paper toxicity. Given how long these patients live, often they don't really have the more serious sequelae of elevated phosphate levels, even if they're not completely adequately controlled. With that being said, sevelamer and other agents and low phosphate diets are ways to manage this.
Amit, anything you want to add to that in terms of your experience with these agents, and any situations where you might use it up front, older patient who you don't want to give chemo to?
Yeah, so approval, again, FDA approval is in the second line or later, but in clinical practice, right? I mean, if you know someone has FGFR2 fusion, we tend to use it sooner than later, right? So if there's a reason, hey, patient is not tolerating chemotherapy or some other reason they cannot get it because the renal issues, yes, we'll use in FGFR2 fusion. We tend to think, we don't know that, is that in the first line activity should be at least similar, if not higher, right? I mean, we see it in all tumor types of first line activity, the responses are much higher than second line, it drops dramatically. So that's why we were trying to do the first line trial, but unfortunately, because of timing and the design of the trial, we're not able to accrue.
Yeah, we're going to bring this issue up with some of the other targeted treatments. And again, of course, obviously non-small cell is really the paradigm for first-line targeted therapy, and they don't always use it first-line there either. Depends on what the target is or the targetable mutation is. All right, let's hear a little bit about HER2.
Yeah, so HER2, very exciting. It started with the breast cancer, obviously, and it's really changed, transformed some of these treatment for HER2 positive tumors. And then slowly, then it trickles down to bile duct cancer, some rarer cancers, right? So there are various ways to target HER2. It started with just simple antibodies, but now we have tyrosine kinase inhibitor. We have ADCs, or antibody drug conjugate. So we have an antibody, then it is conjugated to some sort of a payload or chemotherapy payload. And then we also have a biapoptotic antibody where it binds to 2 sites, and we'll talk about that as well. And if you look at and then there are like T-cell engagers, so they're all different kind of T-cell-like therapy as well in the anti-HER2 therapies. And there are so many different drugs, all targeting different mechanisms that are being developed in this disease. I'm talking about HER2 in general, not just necessarily for bile duct cancer. So first we'll talk about trastuzumab deruxtecan, or what we call it TDXD. It's an, again, monoclonal antibody attached to a linker to a topo-1 inhibitor, which is a payload. And this was called a Destiny Pan-Tumor 2 trial, which accrued different tumor types. And this actually led to FDA approval for kind of like HER2 positive, like pan-tumor, which is great for our patient population, because sometimes it's hard to accrue in a rare disease. So like just looking at the bile duct cohort, I think the response rate were upward of almost like 56%, if you just look at the patients who were HER2 3+. But if you look at HER2 2+, it was about 22%. So we did see activity both in HER2 2+ and 3+, but again, much higher responses in HER2 3+. The duration of response was about 9 months. And these are some of the toxicities. Again, I think the main toxicity that we are seeing is the GI toxicities and the cytopenias. And there's a rare something called interstitial lung disease. But again, the main toxicity in GI or cytopenias. This is, again, median PFS. Again, that's just in the bile duct cohort. For the patient with IHC 3+, it was 7.4 months. For the IHC 2+, it was 4.2 months. Looking at the median survival, again, it translated into the survival differences as well, with IHC 2+ only 6 months compared to 12.4 months for IHC 3+. So again, patients with 3+, HER2 3+ by IHC, have much higher response rate, much have higher PFS and OS compared to HER2 2+ when they receive this therapy. Based on this results and very exciting results, we are again seeing activity in this refractory patient population. They're actually doing a first-line trial as a targeted therapy, where they have 3 arms. One is a single-arm TDXD, then they are combining TDXD with rivilostomig, hard to pronounce. Basically, this is an antibody that actually inhibits both PD-1 as well as TIGIT, and to the standard of care, which is currently gemcitabine plus cisplatin plus durvalumab. And patient can have IHC 2+ or 3+, but they'll have a stratification arm, so they will look at differences between the two. Then the second is a zanidatamab, which is a biparatropic antibody. And so the difference is in this antibody, instead of binding to one epitope, it binds to 2 epitopes, epitope 2 and 4, which enhance the HER2 signal blockade, increase immune-mediated cytotoxicity, and HER2 internalization. We've certainly seen more activity with this as compared to just antibodies that just bind to single epitope. And this was one of the biggest trial in actually BTC for some like a targeted, like HER2 targeted therapy. So for patients with HER2 positive tumor, they had accrued at about 80 patients, response rate of 41%, median PFS of 5.5 months, and median survival of 15.5 months. And again, if you look at, again, 3+ and 2+, there's distinct difference. There's no doubt about this, right? The response rates with 2+ was only 5% compared to 51.6% with in IHC 3+. And same with the median survival was 18.1 months for patient with IHC 3+, only 5.2 months for IHC 2+. So this led to FDA approval for patients with bile duct cancer with IHC 3+ HER2 positive tumor. With responses, it also leads to improvement in the quality of life as well as their pain score, which is not like totally surprising, but it's good to have this quality of life data. So not only we're hoping to have responses and improving survival, but we are actually improving their quality of life. In terms of the side effects, again, the main side effects was the diarrhea and the infusion-related reactions. So something manageable. We did see some decrease in the ejection fraction, but it's only about in 6% of the patients. Based on, again, this amazing data, they're actually doing a first-line trial, Horizon BTC 302, where their patients will be randomized based on, again, it has to be a HER2 positive tumor for GemCis plus PD-L1 inhibitor versus GemCis plus zanidatamab plus minus PD-L1 inhibitor. And the primary endpoint will be PFS in this study. This is just a pooled analysis. So again, we're kind of seeing what we talk about, like responses in 30 to 40% of the patients, and we're seeing survival almost about a year in these patients. So in terms of the future, I think we're really excited, right? I mean, we now have 2 drugs which are approved, zanidatamab as well as TDXD, and now both of these drugs are being tested in the first line. So hopefully, I think we'll move these drugs in the first line, because in the first line setting, you can really make a much bigger impact than as compared to a later line of therapies. This is lastly, my last slide. I was just talking about treatment landscape currently. It continues to change. But right now, for any patient who comes with advanced biliary tract cancer, the first-line therapy will involve GemCis with some immune checkpoint inhibitor, either Durva or Pembro, And if they progress, then based on the biomarker therapy, we can actually select so many therapies. I mean, Neela was just talking about how it is becoming like a non-small cell cancer. Like it's really, if you're MMSI high, IDH1 mutation, BRCA mutation, FGFR fusion, HER2, BRAF alteration, NTRK fusion. I mean, these are the, actually we have FDA approval, not just data from the clinical trial. But unfortunate fact is a lot of patients still don't have targeted therapy and has to be getting second line as a chemotherapy bucket where they get FOLFOX, FOLFIRI, which has somewhat activity, but somewhat limited activity. So we really, really need to get better, and hopefully we'll find more targeted therapy, especially by targeting KRAS and other agents which are much, much more common.
So before we get to Faye's case, because she actually has a patient with an IDH1 mutation, which we didn't talk about, but we want to hear about in a second. But first, kind of getting back to HER2. Mitesh, we just did a webinar with John Bridgewater, and in preparation for that, I did Zoom interviews with a bunch of general medical oncologists, and we were getting in, a couple of them had cases of HER2-positive biliary cancer, and zanidatamab had just been approved, and they were like, what is zanidatamab? This happens every day in oncology. A new agent comes in, it's, quote, a bispecific, raises questions. Of course, it's a different kind of bispecific, but it's so challenging when new agents come in. You can read and see the papers and numbers, et cetera, but they want to hear. Of course, John has a lot of experience with zanidatamab. He actually is, saying, hey, this is extremely well tolerated clinically. But of course, the key question here that we outline here is, putting aside reimbursement issues, what's your typical second-line therapy in a patient with a HER2? We'll start with a HER2-positive disease, and I'm also curious about what we call HER2-low in breast cancer. But what comes first, Zani or TDXD, and does it depend on the clinical situation?
Yeah, I mean, if the HER2-positive, I'm assuming IHC 3+. In this case, my go-to agent is zanidatamab because there's a low rate of serious fatal events with trastuzumab deruxtecan. So you can always give it later after failure. We don't know if it will work as well, of course. But given the high response rate of zanidatamab, very well tolerated safety profile, I tend to go with Zani first.
What about the symptomatic patient, Mitesh, with high volume disease? Still Zani?
Yeah, same thing. I mean, the time to response is pretty quick, even with Zani. So you get your tumor burden reduction and symptom reduction hopefully aligned if you use it.
Amit, TDXD has been out there a little bit longer. I'm curious about your clinical experience with it in terms of how patients tolerate it. Also curious in terms of what you've seen in terms of responses and what you do to screen for ILD. Do you do frequent imaging, for example?
Sure. So I mean, we have definitely much more experience with TDXD just because it has been out there, right? It has been used in different disease types, and we certainly have used it in bile duct cancer as well. I do agree, we have more data with zanidatamab, so if there's a choice, I'll use zanidatamab. In terms of how do you screen for interstitial lung disease, basically mainly symptomatic. I mean, most of these patients, we are doing de-staging scan every couple of months anyway, so we'll get the lung pictures anyway, but mainly it's the symptoms, right? Symptom driven. So if a patient has shortness of breath or cough, anytime they just suggest you have to do a high-risk CT and then make a decision accordingly.
So Mitesh, have you used zanidatamab? Do you have it on clinical trial, or maybe since it's been approved? And
I've used it in clinical practice. I happen to have a whole stash of HER2-positive patients.
Really?
Waiting to be treated, and FDA approval was quite imminent. So my clinical experience with real-world data is pretty similar to what's reported in the study.
What about GI toxicity? We were talking about that in the GYN program, but again, it's interesting outside of breast what you see. In breast, you hear a lot about potentially severe emesis, even delayed emesis. What have you observed with your patients?
Nothing too substantial, but I mean, if you look at the study results, there is some GI toxicity, just like you would with trastuzumab, pertuzumab regimens, and we're quite adept at managing those.
So we're going to hear about this case that Faye has of a 74-year-old man. What happened with him?
Yes. So actually, I have a question before that. I'm just hoping about that cancer stage 4, just like breast cancer, it can be upfront incorporate like Herceptin Perjeta, that's upfront for the treatment before you go to TDXD.
Yeah, Amit, any thoughts about that? Trastuzumab plus chemo plus IO, as
Yeah.
in the gastric cancer?
Yeah, I think we are doing the two phase 3 trials that they're looking at. I think that would answer that question, right? I mean, I think trastuzumab has somewhat limited activity as a single agent in this disease. We don't know with combination with chemotherapy. It makes a lot of sense, but I think the two phase 3 trial would answer that question.
So any other questions you're going to tell us about the 74-year-old patient?
Yeah, no. This 74-year-old man, so he presented abdominal pain and the weight loss, just very typical presentation. And then, so the CT scan showed the multiple liver masses, and one of the masses was 10 centimeters, so the regional lymphadenopathy. And then the NGS study showed the IDH1 mutation positive, PD-L1 was 1%. So he received 6 cycles of cisplatin plus gemcitabine and there was lutuzumab, and then improved and then maintenance darolutamab, only 3 cycles, disease progression. At that moment, he said, I don't want any more chemotherapy, and then so he received the target treatment, IDH1 inhibitor, which is the evolocumab. And then, so after 4 months, then disease progression again. And then, so he went back to FOLFOX plus pembro for 2 cycles, and then went to hospice. I just want to know, expert, are you going to do differently for this case?
So, Amit, any thoughts about this case? Any situations where you might use an IDH inhibitor like ivosidenib up front? Also, do you ever see differentiation syndrome with biliary, as you see with acute leukemia?
Yeah, so a couple of things. So ivosidenib, the drug has some activity, but we typically do not see responses. So it's not as exciting as, say, when you say FGFR therapy, where we really, or a HER2 therapy, we're expecting response. So we do not expect response if ivosidenib. And what you described as a patient is very typical, that at some point, sometimes they have stable disease for some period, but many patients will progress in the first scan. And there are some patients who have prolonged stable disease with this disease. So we do see that, but we don't see typically responses. So differentiation syndrome we might have seen in one patient, but it's questionable because, again, we are not seeing that kind of responses, so we do not expect that as compared to leukemic patient where they actually see responses. I think one of the interesting thing about your case is when it always comes up, so in the trial, with the TOPAZ-1 trial, when we look at GemCis Durva, they do maintenance Durva after up to 8 cycles, and they stop chemo, the patient. And that's a discussion that we frequently have with the patient, is to discontinue chemotherapy and just continue with single agent IO or not. We know it's a very limited activity with single agent IO, and some patients hate to stop it because they're afraid the cancer will start growing. And then some patients I'm done with chemo, it's okay, it's good to give me a break and prevent for better quality of life.
What about targeted therapy, like maintenance ivosidenib?
That actually makes a lot of sense, but again, we don't have any trial data to suggest that kind of approach. But actually, if we were to use ivosidenib, I feel like the maintenance setting is the best. Typically, we use it again in the second line. We don't want to use it in first line because of the limited activity. And then we see somewhat similar to what she described as a case in terms of the effect on treatment. So.
Mitesh, anything you want to add to that?
Yeah, I mean, it's important to keep in mind that targeted therapy doesn't necessarily equal highly effective therapy with some agents, and ivosidenib fits that bill with single-digit response rates in the phase 3 Clarity study. But there's a tail of about 10%, as Amit mentioned, that has very, very prolonged stable disease, akin to what we are used to seeing with immunotherapy.
Interesting. So we're going to go on now and talk about upfront treatment, and particularly the use of checkpoint inhibitors in upfront situation. But before we start taking a look at the data, again, in talking with Faye, one of the issues that she was interested in was the issue of locally advanced biliary tract cancer. Faye, can you kind of elaborate on what the questions you have about that?
Yes, so I got a few cases. The patient came to me and then they want to do, it sounds like neoadjuvant treatment, and then actually those patients usually monitoring by the surgeons. And then we do the scan every 2 months, and then to see if the patient turned to be a surgical candidate. So, for example, I have this 68-year-old man, from Central America, and then he presents abdominal pain, jaundice, and then weight loss. So then imaging study showed the multiple liver masses, and the largest one was 5.6 centimeter. And then there's some just a small hilar lymph node enlargement. CA99 was more than 1,000. NGS study was without any actionable gene mutations. So PD-L1 was 10%. And then so he had standing, bile duct standing, and then the bilirubin dropped some from 21, dropped to 4 to 5. And then as I worried about the gemcitabine. I don't know what your experience, but then I gave FOLFOX plus the immunotherapy pembrolizumab, and then total gave 8 cycles. Actually, patient really improved. Jaundice completely went away, and then he felt better. He came with a big blood clots, lung, leg, and all went better. But now the surgeon told me, hey, you need to change treatment because the imaging study showed the slight progression. Actually, we did not know those. It's only in the imaging study. And so at that time, I changed to cisplatin plus Ginza and continued pembrolizumab because patient really improved. And so, but after 6 cycles, not improved, it's kind of never been surgical candidate, eventually, of course, progressed. And then, I don't know, what's your experience for those, is it really possible neoadjuvant,
Mitesh, any situations where you've seen patients be converted from unresectable to resectable?
Yeah, it's low. I mean, that's the reality. It's sort of in the 10% range, and even those I would think they're somewhat more, borderline, close to locally advanced type of cases, as opposed to the, Fulman and locally advanced cases, which are never going to become resectable. So I don't think it's unusual that if you have seen a few patients that you treated and none of them went and got downstage, the numbers are really in the 10% range at best.
All right, let's take a look at some of the data, particularly related to emerging data with checkpoint inhibitors, Mitesh.
Okay, all right. Okay, so as Amit went over with regards to the anatomy, BTCs, biliary tract cancers, is a bucket, including extra hepatic cholangiocarcinoma, perihilar cholangiocarcinoma, and gallbladder cancer. And many of these are diagnosed at late stage, 3 and 4, which is where you're going to get into the locally advanced and metastatic disease. And of course, we don't have early detection tests, hence we see this, and there's probably aggressive behavior. So even a lot of patients very early are presenting with advanced disease. So most of the patients you'll see in oncology are actually the patients diagnosed with this disease. 60% are advanced. So start with a case here, 40-year-old female with metastatic intrahepatic cholangiocarcinoma, good performance status, mets in the liver, lung, and bones, low tumor mutational burden, PD-L1 is less than 1%, P53 and SMAD4 mutations in the tissue, good organ function, and no ongoing myelosuppression. I'll add that she didn't have any germline genetic findings either. So what regimen would you consider for systemic therapy? FOLFOX, bevacizumab, Gemcis durvalumab, Gemcis pembrolizumab, or either 3 and 4. And I know we don't have IRS here, but...
We have Amit here. What do you think?
Yeah, so I think either number 3 or number 4 would be a good choice. So Gemcis with either durvalumab or pembrolizumab would be the first-line choice for us.
Yeah.
Any situations where you slip in carbo instead of cis?
Yeah, and we'll get to that actually in the slides that I'll show. Great question, though. Okay, so as historical background, you have the ABC02 study that laid down Gemcis as the standard. It was based on just a UK study, and interestingly became an international standard. So you can see it was gemcitabine cisplatin versus gemcitabine, and here they limited it to 6 months of treatment. and the primary endpoint was overall survival. And the survival improvement was in the 3.5-month improvement range, getting it closer to a year of survival with this therapy. And you can see that it was highly statistically significant at 0.02 p-value and hazard ratio of 0.7, so 30% decrease in mortality. You can see that as all patients are followed for a long time, you don't really have a tail here, so chemotherapy sort of moves the curve rightwards, but it doesn't provide any cures. And then there's no factors that really drive the benefit. There was some crossing the unity line with peri-Heilers, but that could be because of the smaller number of patients in that subgroup, but everything else you can see is on the other side of the unity line. Okay, so the first study that provided checkpoint inhibitor benefit evidence was the TOPAZ-1 study, which utilized durvalumab compared to placebo, added to gemcitabine and cisplatin. Here it was limited to 6 months of the chemotherapy backbone, and then you could continue the durvalumab thereafter, 680 or so patients, and primary endpoint was overall survival, and you can see the secondary endpoints which span efficacy and safety. So the overall survival benefit was modest from a median perspective. You can see it's a little over a month, but you can see in the figures there that there's a tail of the curve, and I'll get to that in a little bit. There was a higher response rate, slightly higher PFS. Importantly, there was no increase in adverse events when you added the checkpoint inhibitor, although you still have to be careful about the immune checkpoint inhibitor toxicities, which can occur in a small proportion of patients. And the response persisted in a subgroup of patients, and that translated into PFS and OS advantages from a landmark standpoint, as I'll show you. So here's the follow-up of this study, and you can see that 1 year, 2 year, and even 3 year overall survival is higher in the immunotherapy combination arm by a factor of 2 to 1 when you get to 3 years. So there's a group that benefits significantly from the immunotherapy, and likely, as we'll follow for 4 and 5 years, I'm sure you'll still have patients who are alive with this treatment. Keynote 966 is the second study. So here it's pembrolizumab instead of durvalumab. The major difference here was that you could continue the gemcitabine beyond the 6 months, which is more similar to clinical practice. If a patient is benefiting and tolerating the combination, why stop, at least in the US? This was one of the largest phase 3 studies conducted, over 1,000 patients. Primary endpoint was overall survival, and similar secondary endpoints as the TOPAZ study. So here also you can see that the benefit is modest from a median perspective, but hazard ratio is 0.7, p-value is quite low. There was no difference in the PFS because they put the threshold quite low for this study. It wasn't 0.05 like we have in most studies. The response rate was not any different here. Again, safety is similar to just giving chemotherapy. And similar to the TOPAZ study, you have benefit that persists at that sort of 12-month, 18-month, 24-month timeframes. And I'm sure there'll be longer follow-up on this study as well. Okay, so now in patients who can get it, adding a checkpoint inhibitor is considered the standard in the first-line setting. This is the question Neil asked about, which is, well, my patient doesn't fit the study, right? And I love the things that are being studied in the Tourmaline study, trying to address real-world questions, which are, can you give it every 2 weeks? That's an arm here. What backbone can I use? Can you use gemcitabine? Can you use oxaliplatin combination? Can you use carboplatin combination? S1 for Asian geographies. And can you use a gemcis Abraxane combination? Of course, there may be lower enthusiasm now with the negative SWOG study, but at the time of the launch of this study, this was relevant. And can you give it every 2 weeks instead of day 1 and 8. This commonly comes up as well. And can the infusion time be shortened? So all of this is being evaluated in this study. Can you look at ECOG 0 to 2 instead of just 1, right? So this is some early readout from this study, and the regimens were generally fairly well tolerated, similar to just giving chemotherapy like the TOPAZ and Keynote 966 studies. But the final results have not been published or reported yet, so this is just an early readout. But I think many important considerations here. And as I said, there's no new safety signals. Interestingly, in the every 2-week regimen, it's only 4 patients, but it seemed like there was lower toxicity, so this is probably one to keep an eye on. Okay, so the preliminary conclusions have been it's generally manageable using other backbones. You don't get more infusion reactions if you decrease the duration of the infusion to 30 minutes, and more data to come, as I said. Okay, so we'll go back to the same case, and this patient has, now progressed on first-line therapy. So the question would be, what regimen would you consider using in this patient? FOLFOX, 5-FU nanoliposomal irinotecan, tremelimumab, or either 1 or 2?
So, Amit?
Yeah, so I mean, in our practice, we use FOLFOX based on the ABC06 trial. The 5-FU nanoliposomal irinotecan was interesting. The NIFTY trial actually was positive, but unfortunately the European trial was negative, so that put a little bit of pause. But so typically the second line we have used FOLFOX as our standard of care. So.
Yeah, so I think either 1 or 2 seems a reasonable approach. So this is the ABC06 study that Amit mentioned, which looked at FOLFOX versus best supportive care, again a UK study. And there was a very modest survival improvement, less than a month, so it's hard to call it like a standard of care. It's an option. I would put it that way. Okay, and then here's the NIFTY study. This was a study from Korea. You can see it was 5-FU leucovorin versus 5-FU leucovorin and nanoliposomal irinotecan. And this was a phase 2 study, so the survival was a secondary endpoint, but the PFS was higher with the NIFTY regimen, and the response rate was higher but not statistically significant. And the survival was higher but not statistically significant because it wasn't powered to address this question. The safety would be what you would think, higher rates of diarrhea, nausea, and vomiting when you add in the nanoliposomal irinotecan. Okay, and then something to keep in mind with new agents. There's a bispecific, I like to call them multivalent engagers, so you're not thinking of immunotherapy when you bring up bispecific. So this binds VEGF and DLL4, which is a ligand for the Notch pathway. And this is in a phase 2 study comparing paclitaxel versus paclitaxel with this drug in the second-line setting, and the primary endpoint is response, and then you see the other secondary endpoints listed there.
Really interesting. So a couple of questions coming back to Amit. In terms of the use of IO plus chemotherapy in the first-line setting, what about the patient with prior autoimmune disease, prior renal transplant? The benefit here doesn't look that gigantic, but would you treat a patient in what type of situation?
Yeah, so I totally agree. The benefit of IO is, at least in the median survival, is very, very marginal, right? So it's a whole risk versus benefit. So it's hard to argue that we should do therapy, especially in the patient who have undergone transplant where you risk graft rejection in that kind of setting. Autoimmune disease is a big bucket, right? It depends on what kind of autoimmune and how active it is. One thing I would have to mention that when we combine IO with chemotherapy, we tend to see a little bit less IO-related AEs as compared to IO alone, whatever that is. The most of the side effects are driven by chemotherapy. So we have used in autoimmune disease definitely the triplet combination, or basically use of IO with chemotherapy. But it depends, as long as it's not very active. I mean, if someone has active like UC or something and having bleeding, obviously, and requiring therapies for that, that would be hard to argue or justify using IO in that kind of settings.
So we were talking in the beginning about these mixed cholangio HCCs, and Emily actually has a 51-year-old man. This is Emily in the audience. Stage 4 metastatic mixed tumor. So she treated the patient with gemcitabine, no actionable mutations. The patient is now progressing. Mitesh, what would you think about second line? Would you go to a more traditional HCC treatment?
Yeah, so in the absence of clinical studies, right? So clinical studies would be considered a very desirable approach for these patients who don't have great outcomes. And then what's actionable and not actionable is always changing. So, for example, KRAS mutations are becoming more actionable in the context of trials, at least, a lot of RAS inhibitors. So it may be worthwhile going back to the profile and seeing, are there new agents in that regard. Chemotherapy won't have much benefit, as we just showed with both the ABC06 and NIFTY studies, so it wouldn't be unreasonable to use an anti-angiogenic in this setting. Even rebiopsy could help. Has it shifted more towards an HCC phenotype at this stage? That could drive your decision as well. So an anti-angiogenic like lenvatinib wouldn't be unreasonable.
What about some atezobev or tremi-durva?
Well, this patient already got checkpoint inhibitors, right? So continuing checkpoint inhibitor in the setting of progression.
Durva-tremi.
Yeah. So CTLA-4 antibody could be reasonable.
So actually, Faye, you have another case, or case 3, the 64-year-old woman that looks interesting. Can you talk about her?
Yeah, so this 64-year-old woman, incidental finding cholecystectomy, PT1 lesion, and then went for more liver resection, and turned to be PT3 lesion, N0, and then afterwards, the adjuvant treatment, poor tolerance, just 1 month of combined gemcitabine plus capecitabine, and then single agent capecitabine for another 2 months, and couldn't tolerate more. And 8 months later, recurrence peritoneal carcinomatosis. And I was wondering, do you do it differently? And then how about, is there anything on the way pipeline for the adjuvant immunotherapy for this patient?
Mitesh?
So the only adjuvant therapy in clinical practice we've been using has been capecitabine for the most part, in the US at least. And even that study was actually negative. There was a per protocol pre-planned analysis that was positive. The intent to treat was actually negative. But given there aren't great options, I think capecitabine remains acceptable in clinical practice. There is a study called the Artemide study, which is going to look at that TIGIT PD-1 bispecific that Amit mentioned, rilvegostomig, in combination with capecitabine. So I think that would be one to keep an eye on.
Without PD-1?
Yeah, it's PD-1 plus TIGIT,
right,
in the same drug.
Right. So Amit, Shobha in the audience here wants to know any role for transplant in patients with cholangio?
Yeah, so that is being done at different centers. So Mayo is one of the first to start, especially for hilar cholangiocarcinoma, is a huge program. For intrahepatic, just started at Mayo, and there are some other centers which do it for intrahepatic cholangio, but they're very, very limited. It has to be fit that criteria, and you have to have disease stabilization for over a year. But there are only very few centers who does for intrahepatic cholangio. But for hilar cholangio, we have a strong program at a lot of different places that all patients should be evaluated for, as long as they don't have metastatic disease and have localized disease unresected.
Have you had patients actually get transplanted?
Yeah, a lot actually. Yeah.
Really?
We've done. Yeah, there's a big series from Mayo. Yeah, a huge series where they have done lots of transplant for these patients.
Oh, fascinating. All right, so we're going to move on. Thank you so much.
Thank you.
Thank you.